All right, in this section we're going to talk about health status. And health status is generally the overall health condition of a given population. That population could be a family, it could be a city, it could be a county, it could be the entire country. But we're looking at characteristics of that population in regard to diseases or health. We happen to be based in Mississippi, and in this case it's a good thing because Mississippi provides a wealth of health status data that we can look at. Mississippi, as you probably already know, ranks very high in a number of disease processes, including heart disease, diabetes, stroke, and a number of other high-profile diseases. And since we rank so highly, we get studied a lot. And since we get studied a lot, we have lots of data that we can look at and we can utilize as we attempt to create interventions to help stem some of those trends that we see in Mississippi. Okay, so where do we get this data that we want to utilize? We have a lot of sources. We can use census data. We can use vital statistics provided by the State Department of Health, or virtually every state provides that type of data that is very similar across state lines. We can use surveillance data. We can use data provided by the Centers for Disease Control in Atlanta. The CDC gathers a huge database, ongoing database of information for every state in the country. So we know we have lots of sources of data, but why are we gathering that data? Are we gathering it just for the sake of gathering data, just to write papers, just to get things published? Well, hopefully not. Hopefully we're gathering this data so that we can study it, so we can find solutions for some of these problems that we see in Mississippi. For example, if we gather data on diabetes, we can find trends. We can find reasons why we have so many diabetics in Mississippi. And somewhere buried in that data, we can find clues regarding how to reverse those processes or how to stop those processes before they start, or as a last-ditch effort, how to treat those processes once they have developed. But the purpose of gathering data is to make it useful, to make it practical, to turn it into something that we can utilize. We're interested in gathering data for three basic reasons, at least in this course. The first is to basically look at demographic characteristics to establish a baseline. In other words, we want to know what we have. We have to have a starting point, and we can't really start anything until we know the existing condition and know what we have to start from. The second thing we're going to be interested in is program planning. Once we've looked at these demographic characteristics, we understand the incidences of health and disease, then we can start looking at things that need to be fixed. We can start developing programs to intervene to help prevent those diseases from occurring or to treat those diseases once they have occurred. And that can be done on a group or an individual basis, but we're more interested in looking at it from a group basis. The third thing we're interested in is performance improvement or performance measurement. Once we create a program, then we have to have a means to look at that program to see whether or not it's effective. And that's where performance measurement or performance improvement actually comes into play. And performance measurement is going to be ongoing. It's going to look at retrospective data. It's going to look at real-time data. And it's going to hopefully influence what happens from that point forward. We can take the information we've gained from the demographic data and we can begin to look at diseases across populations. One of the ways we do that is by looking at disease-specific mortality. And what that means is we look at a given population, for example an age range, and we see which diseases are most likely to affect that particular age group. Once we identify the highest ranking diseases for that age group, then we can begin to set priorities, and we can begin to focus on studying those particular diseases that have the highest incidence and looking at ways to reduce the incidence of those particular diseases. The incidence of disease and causes of death can vary tremendously across age groups. One of the best examples to look at is trauma caused by motor vehicle crashes. And we know that the age group that is most likely to suffer trauma because of motor vehicle crash are teenagers just learning to drive. We also know that we have a U-shaped curve, and the U-shaped curve stems from a very high rate of crashes and deaths in teenagers, which drops off across middle age, but then begins to increase again in the elderly as we get up into that 70 and 80 year range. So we know that the number one category for us to be concerned about is teenagers by far, because their incidence of crashes and injuries is the highest by far. But then we also have a little blip in the elderly population. By blip, I mean it's not nearly as high as it is with teenagers, but it starts to go up again as people start to lose their mental faculties and their physical attributes begin to decline. So those are the two groups that we need to focus on when it comes to motor vehicle crashes. Okay, as we look at these next two slides, pay particular attention to the differences in causes of death. When you look at the 25 to 44-year-old age groups, you see several things that don't even appear on the 65-plus age group, and vice versa. And this is interesting from several different perspectives, and we'll talk about this some more in a later segment. But just to get you started thinking a little bit, accidents, suicide, and homicide are on the 25 to 44-year-old age group, but they're not on the 65-plus group. On the 65-plus group, you've got stroke and Alzheimer's are two very big causes of death. So we have a very finite amount of money and amount of effort that we can allocate to disease prevention and treatment. So should we focus on accidents, suicide, and homicide, which affects the younger age group, or should we focus on stroke and Alzheimer's disease, which affects the elderly? And so you can see some of the dilemmas that you may have to face down the road as you get into the administrative field when you are at least influencing the direction that money is taking and the efforts that your money is being spent on along the lines of disease prevention or treatment. This section focuses on measuring health status, but I'm going to skip ahead just a little bit and go ahead and open a topic that we will refer back to later in this course and throughout the program. If you look at these two slides that have causes of death listed on them, most of those are preventable, or at least there's a good opportunity to reduce the risk through lifestyle modification. And the question is, should we hold people responsible who adopt lifestyles which make them much more likely to acquire these particular diseases? There's a classic example that I'm going to use here, and I hope this will help you understand why I'm asking this question. Motorcycle helmets. There have been extensive studies done in several states, Florida in particular, where they've looked at medical costs associated with motorcycle crashes in patients who wear helmets in comparison to those who don't wear helmets. And the conclusions have been that patients who don't wear helmets who are involved in crashes have significantly higher medical costs than do those who wear a helmet. Also, we've learned that motorcycle riders have a higher than normal average of not having private insurance. So we know that the public will pick up the cost for a significant percentage of the cost of a motorcycle crash. Therefore, the public has a vested interest in whether or not patients wear, or whether or not motorcyclists wear helmets when they ride. So the question then becomes, does the public have a right to demand that motorcycle riders wear a helmet when they ride? And obviously lots of issues come into play here. But if a motorcyclist who doesn't wear a helmet is going to take more out of the pocket of a typical consumer than is the motorcyclist who wears the helmet, an argument can definitely be made that society has a right to make all motorcyclists wear helmets. Now that's a case where we've got lots of data and we know what the costs are, we know what the risks are. If you go back to our chart again and look at these leading causes of death, we can do the same thing here. We may not have quite as much data in some cases, but we do have some data. And we do know that obesity is associated with a significant increase in heart disease, certain types of cancers, and stroke. Therefore, the same question can be asked about obesity. Should we make patients who are obese pay higher insurance premiums? Should we exert influence on them to make them lose weight in the best interest of society? And I want you to kind of be giving that some thought. I don't want you to answer right now necessarily. What I want you to do is be looking at both sides of the issue. And we may see this in a paper coming up down the road. But I want you to be able to argue both sides of the coin here. And then I want you to be able to pick one and substantiate an argument for whichever side of the issue you select to support. An ongoing problem facing healthcare administrators is emergency department overuse. Many patients that go to an emergency department are going there seeking primary care. They're not there because of an emergency. It is estimated that roughly 25 to 30% of all the patients who show up in an emergency department could be served by going to a primary care clinic to see a nurse practitioner or a physician in private practice. They do not need urgent care. Their condition is not timely, and they would do just as well seeing someone outside the emergency setting. In many cases, this practice results from inadequate money to pay for private care. In some cases, it's just ignorance. Patients don't understand that the emergency department is not supposed to be utilized for primary care. But in any case, when you start dumping primary care patients into the emergency department, it clogs the wheels, it slows down access for patients who really do need emergency care, and it is just an inefficient use of resources. So the question then becomes, how do we correct that? Are there steps we can take to change the thought process of these patients who go to the emergency department for primary care? This problem has been addressed by literally hundreds of hospitals, hundreds of healthcare systems, academics, you name it, over the last 30 years. Some valid solutions have been developed. Probably the most efficient systems that have been developed incorporate primary care into an emergency department area. For example, a fast track area where when patients come in, they're triaged. Patients who require emergency department service are continued on to the emergency department. Those who really only require primary care are then filtered off and sent to an adjacent area where a primary practitioner will see those patients in a clinic-like setting. And what that does is it sorts the patients into appropriate categories and better matches them with available resources. This is another topic that I want you to be giving some thought to now that we will come back to again later on. But I want you to be just mulling around in your own mind ideas for ways to help to prevent this problem from continuing, ways to discourage patients who don't need emergency services from coming to the emergency department, perhaps alternatives for seeing those patients, just any type of a solution that you can come up with that might help to make this problem improve. For this assignment, we're going to look at obesity. And obesity is a huge problem nationwide, but it's even a bigger problem here in Mississippi. As you probably already know, Mississippi came out #1 again in the incidence of obesity. We're right around 34%, meaning that more than 1/3 of the citizens of our state are obese. Now, I want you to look at the definition of obesity and understand that obesity does not mean you gained a few pounds. Obesity means your weight has reached a level where it is a serious detriment to your long-term health. I want you to look at historical variables that may have changed, that may have led to this significant increase in the incidence of obesity. And just to get you started, obviously you're going to look at the fast food industry as one of those variables, but there are lots of others as well. I want you to look at the disease process. We're not in a medical program, I know that, but I want you to at least scratch the surface. I want you to have a little bit of an understanding of what happens when a body becomes obese, why that is such a serious concern, and what some of the secondary diseases that can occur because of it are, and why those diseases might develop. Discuss the financial implications. Look at the reasons why insurance premiums may go up. Look at why the individual or each one of us as individual insurance payers might see increases in our premiums. Look at the reasons why when we go to the hospital we might have to pay more up front because of obesity. And the biggest part of the project, I want you to work on a program that you will administer. You're going to be the administrator of a small hospital, and you want to develop within that hospital a voluntary program to encourage your employees who are overweight or obese to voluntarily take the steps necessary to lose weight and to keep that weight off. I want you to be as realistic as possible here. Obviously there's going to be resentment, or some people are not going to want to do that. I want you to explain how you're going to overcome those issues. I want you to explain how you're going to get buy-in from these people, how you're going to encourage them to participate in the program.